Brugada syndrome. This is an ECG abnormality with a high incidence of sudden death in patients with structurally normal hearts. Brugada syndrome is due to a mutation in the cardiac sodium channel gene. This is often referred to as a sodium channelopathy. 12-lead ECG typical of Brugada syndrome shows characteristic down-sloping ST segment elevation in leads V1 and V2 and QRS morphology resembling a right bundle branch block. Coved, mnemonic, type 1 Brugada pattern. Type 1 is the only diagnostic pattern. See coved ST elevation, more than 2 mm. O, outward then downward sense segment. V1 V3 leads involved. E ending in inverted T wave. D dangerous, diagnostic plus highest risk. Saddle, mnemonic, type 2 Brugada pattern. Type 2 is not diagnostic but suspicious. S saddleback ST elevation. A atypical morphology. D depressed ST between two peaks. D don't diagnose, not definitive. L leads V1 V3. E evaluate further. Clinical management. Syncope and cardiac arrest are common clinical manifestations. In many cases, cardiac arrest occurs during sleep or rest. To date, the only treatment that has proven effective in treating ventricular tachycardia and fibrillation and preventing sudden death in patients with Brugada syndrome is implantation of an automatic implantable cardiac defibrillator, ICD. No pharmacologic therapy has been proven to reduce the occurrence of ventricular arrhythmias or sudden death. However, theoretically, drugs that counteract the ionic current imbalance in Brugada syndrome could be used to treat it. For example, quinidine. This ECG abnormality must be associated with one of the following clinical criteria to make the diagnosis: documented ventricular fibrillation, VF, or polymorphic ventricular tachycardia, VT. Family history of sudden cardiac death at more 45 years old. Cove type ECGs in family members. Inducibility of VT with programmed electrical stimulation. Syncope. Nocturnal agonal respiration.